morning, and thanks for coming, and especially thanks for having us to Cal and Hanan and their teams. It's always a great pleasure to be here and participate and contribute in and contribute to this conference, even if the weather isn't cooperating this year. But we're still really enjoying. I think I can speak for the other international speakers. We're always very honored to be here, and we're enjoying the conference tremendously and everything surrounding the conference. Should I use the... Let's see. Yeah. Is that good? Yeah. Okay, good. So my first talk is about pediatric nephrotic syndrome, and I'll present some fairly recent updates and review some basics that really haven't changed very much first. But again, my disclosure slide, I have no interests or conflicts of interest to disclose. This is the view from our children's hospital that's in a community just outside of Denver called Aurora. This is the view from from one of the pediatric floors where I round when I take care of patients in the hospital, the view west. So you can see the adult university hospital within walking distance, which will become important in one of my later talks. And then downtown Denver is 5 miles or so behind the adult university hospital. And as you know, Denver is called the Mile High City because it is at 5,280 feet of elevation. So the air is a little thinner, the oxygen saturations are a little lower where I work and exercise and stuff. And then, of course, in the background, you can see the Rocky Mountains. This is one of the so-called 14ers, Mount Evans, meaning that peak is higher than 14,000 feet, so almost 5,000 meters. So everything is very high up where we live and work. And as you can see from the trees, this picture wasn't taken in the winter, but nonetheless, there's still snow on the Mount Evans and its neighbors. I talked about the learning objectives already. When I updated my slides for this meeting, I found this very recent article published in 2019 in the Saudi Journal of Kidney Disease and Transplantation that looked at available information in a number of Arab countries about kidney biopsies in children. Not every country has a registry of kidney biopsies, but those that had were included in the study, which was done out of Oman. And the reason why I included this figure from this article is that if you look at glomerular diseases in pediatric glomerular diseases in the Arab world that required a kidney biopsy that was being tracked in some sort of registry, then minimal change disease and focal sclerosis are by far the most common findings on those biopsies if you're looking at primary glomerular disease. We'll talk about lupus and some other secondary glomerular diseases in a different talk, but for primary glomerular diseases worldwide and including in the Arab world, nephrotic syndrome, basically minimal change disease and FSGS are by far the most common findings in pediatric kidney biopsies. So what are we biopsying here? As you can see, obviously, here are the kidneys. We look at the kidneys basically as a conglomerate of tubules and glomeruli. So you can see a glomerulus here and the beginning of a tubule that is basically draining the primarily filtered urine from the glomerulus and then affecting its composition. If you look closer at the vascular structures that make up the glomerulus, you see these very delicate and fenestrated glomerular capillaries that are sort of held together from the outside by these octopus-like cells called the podocytes. And that is where the blood is being filtered into primary urine And if you continue to dig deeper and you look at the ultrastructure of these filtration barriers, then you see this. These are the podocyte foot processes. And in here, this is the fenestrated glomerular capillary endothelium. So below here would be where the blood is, and then the urine comes out this way. And these photocyte processes are connected by this lattice work of very delicate structures that are shown in even higher magnification in this slide. And in this slide, you can see that this lattice work, the components of this lattice work actually have names like nephrin and podocin and alpha-actin and actin. So some somewhat familiar molecules that all are structured together to form this filtration barrier where the urine comes through. And if you look even in more depth at the electron microscopic level here, and then at a similar reconstruction, now looking at it from the side, here's the blood space and the capillary lumen. This is the glomerular basement membrane. You can see the fenestrated endothelium of the capillaries. Oh, okay. You can see the fenestrated endothelium of the capillaries here. And then here are the foot processes. And you can see there are little, whoops, what happened now? Must be the weather. Everything, yeah. I forgot to mention, you saw how blue the sky was in Denver. We have over 300 days of sunshine right there. Hey, right there, perfect. All right, so foot processes and then these little fenestrated networks that contain, like I said, nephrin, podocin on electron microscopy, and here looking at it basically from the top. This yellow thing is a model of an albumin molecule, and you can see that the actual pores in these filtration diaphragms are just small enough to, am I touching something or? Oh, okay. Just small enough to typically not let albumin through, which is why if everything is healthy and working well, there shouldn't be proteinuria. Now in nephrotic syndrome, things change a little bit. This is the same picture I showed you for comparison, but if you look at the electron microscopic appearance of one of these capillaries on kidney biopsy from somebody who's acutely nephrotic, you can see that these beautiful looking stamp-like foot processes are all of a sudden all flat on the outside here of the capillary, or attenuated as we call it, which just symbolizes that, there has been some change in the filtration barrier, and these changes are summarized by changed capillary hemodynamics, shifted capillary wall pore size, and loss of polyanion charge of the normal capillary wall. And the underlying two mechanisms, and that's my first update, the previous version of this slide said altered T cell function or other, namely mostly primary genetic podocytopathies. But we now know that genetic nephrotic syndrome secondary to a podocytopathy can also be accompanied by altered T cell function. So those two categories are no longer completely mutually exclusive. Now, the way we know nephrotic syndrome in our pediatric clinics is usually a child all of a sudden starts retaining fluid, becomes very edematous. It's an old picture. I don't think nowadays we'd be using a lot of bladder catheters anymore. So this happens in about 1 in 6,000 children. 80% of these children are indeed quite young, namely less than 6 years of age. And it happens a little more often in boys than in girls. That obviously hasn't changed. Neither has the morbidity associated with nephrotic syndrome that you're all probably very well aware of. And I always tell parents of my new onset nephrotic patients that in 1950, when we neither had steroids nor antibiotics, actually half of these children died from one of these nephrotic complications. Nowadays, it's highly, highly unusual to have mortality from regular nephrotic syndrome, and that is, like I said, due to the fact that we have steroids to treat that altered T cell function, and we have antibiotics to treat some of these complications. You've all heard about spontaneous bacterial peritonitis and other pretty classic infectious complications of nephrotic syndrome. The classification of pediatric nephrotic syndrome has evolved over time. One way of looking at it is primary versus secondary. Primary nephrotic syndrome almost always is what these kids that look like what I showed in the previous slide walk into our clinics. But of course, there's also nephrotic syndrome secondary to some systemic or other diseases, and some of them are listed here. Getting to probably a more practical and applicable classification that we sort of always keep in mind is that nephrotic syndrome in children historically is either minimal change disease, and I'll say in a moment what I mean by historically, versus other disease. And the reason why I highlighted historically, back many, many decades ago, when I didn't even know that I would become a pediatric nephrologist, there was a time where pediatric nephrologists would biopsy every new onset nephrotic child at presentation, basically. And many, many, many of those biopsies didn't show any abnormalities except for that foot process attenuation that happens in nephrotic range proteinuria that I showed you on electron microscopy. But other than that, the kidney tissue would look perfectly normal, minimal change. And it then turned out that if you treated those children with steroids, they almost invariably would be steroid responders, which then made people think, well, maybe if we have good criteria, we don't need to put all these kids through biopsies. We can oftentimes just treat them with steroids and see if they respond. So we don't usually biopsy regular children, and I'll tell you what I mean by that in a moment, anymore, because there's such a high likelihood that many of these kids will have not just minimal change on biopsy, but more importantly, be steroid responders. And so the steroid response has sort of substituted primary histologic criteria, and the steroid responsive pediatric nephrotics are almost completely identical with kids who you would see minimal change disease on biopsy. And then, of course, there are steroid-resistant nephrotics, which is a very different category that we'll talk about. The criteria we use to decide, is this child a good candidate for empiric steroid therapy, or do we need to be more careful and establish a more specific diagnosis first? Steroid sensitivity is very likely in children who present anywhere between the age of 1 year to 10 years. Some people would extend that to 12 or 13 or 14 years. Prior to 1 year of age, nephrotic syndrome is, as you know, congenital nephrotic syndrome, which is a very different animal than our likely steroid sensitive, likely minimal change disease in this age group. And in this age group, we do feel very comfortable starting steroids empirically in a child with new onset nephrotic syndrome. If there's no gross hematuria, they can have microscopic hematuria on dipstick, but no gross hematuria. If blood pressure and serum creatinine are normal, and if there's no suspicious past medical or family history, that would make us think more about other causes and less likely causes of nephrotic syndrome. So there's good guidelines out there for how to treat those new onset pediatric nephrotics that are likely going to be steroid sensitive. and those guidelines are referenced here. Essentially, you start steroids every day at a pretty high dose, 2 milligrams per kilogram, and you do that according to some guidelines we use for 6 weeks. And the reason for that is that if somebody doesn't respond to steroids at this dose, after 6 weeks, the likelihood that there's going to be a delayed response is extremely low. And not only that, but the likelihood that side effects are going to become problematic from this much steroids given for any longer than 6 weeks also increases. So that's where these durations come from. And then there's a battery of additional initial management things. Depending on what your local incidence of latent tuberculosis is, before starting steroids, in some regions, there should probably be some testing for latent TB. We coach our families to avoid salt in their child's diet to make the edema no worse. Same thing about fluid intake, and we have that guided by home weights if possible. Some centers, some programs will empirically prescribe penicillin prophylaxis if they're really worried by how much ascites there is and therefore increased risk for spontaneous bacterial peritonitis. We try to expedite pneumococcal vaccination. We teach our families to call us if there's a varicella exposure, because that can be problematic on steroids in an acutely nephrotic patient. And we do a lot of counseling about what to look for complication-wise, what to do if their child has a fever, what to do if their child has severe abdominal pain, what to do if there are neurological changes that might suggest a central venous thrombosis. And we teach them home urine protein monitoring by, if possible, equip them with the dipsticks and whatever else they need. We also counsel these families that most steroid-sensitive nephrotics respond to those 2 milligrams per kilogram daily in the second or third week of treatment. Like I said, hardly anybody responds later than 6 weeks. Most, like I said, kids respond within the second or third week of treatment, so these families don't go home thinking, I just have to use these steroids for 3 days or something, and if Johnny doesn't respond in that time, then the doctor made the wrong diagnosis. So how can pediatric nephrologists help? Well, help clearly manage all atypical patients, meaning infants or teenagers, because the likelihood that minimal change or steroid-sensitive nephrotic syndrome is the underlying cause is not as high at all in those age groups, or in adults for that matter. Confirm the diagnosis and initiate alternative second-line treatment in kids who respond to steroids but who become steroid dependent or frequently relapsing. We have criteria for that, or who clearly have evidence of steroid toxicity already. Once again, reassure and counsel everybody. If your child all of a sudden looks like a child on that picture, then there's a lot of anxiety and there's a lot of explaining to do. So this can be pretty time intensive for our team to work with these families. And then recommend a kidney biopsy when it makes sense to do a biopsy, for example, when somebody has failed those 6 weeks of steroids and not responded. And then most recently also help with pursuing genetic testing, and we'll talk about that in just a minute. So what are these alternative second-line options that I mentioned? Well, generally they're indicated, like I said, to reduce long-term steroid exposure and related toxicities in steroid-sensitive children. Historically, there were some options for what we would call second-line treatment that consisted, one, of just keeping these kids on much less steroids every other day at a much lower dose. And that's been shown to be very safe and not very toxic and very helpful in avoiding frequent relapses, which then would come with much higher steroid exposures again that could contribute and increase toxicity. And there are other second-line agents such as cyclophosphamide and mycophenolate mofetil that all work pretty well, but also have their downsides that we can talk about if there's time. And then we also have third-line options historically, namely calcineurin inhibitors like cyclosporin or tacrolimus. Now, more recently, there's been really good data on the use of rituximab as a second-line agent. And there are a couple of reasons why I really like Rituxan as a second-line agent. One is, even though typically if you treat multiple myeloma, you have to give at least 4 infusions of Rituxan to treat these things. These studies that are now available for Rituxan as a second-line agent in pediatric nephrotic syndrome that's steroid sensitive but frequently relapsing or whatever, only used 1 or 2 doses. So you don't have to use a whole 4-week course like you would, or 4-dose course like you would in multiple myeloma. The second reason I really like Rituxan is because it's an infusion. So yes, the day of the infusion is a full day where these kids come to some infusion center or something and get the infusion, but we know they're getting the infusion, and then they come back in a week or 2 and get that second dose, and again, we know they get their infusions. We never quite know how reliable and willing families are to use prolonged courses of even low-dose prednisone or mycophenolate mofetil, which are basically open-end therapies you embark on for a year or 2 and then reassess, or how scared they are to be adherent and reliable with a more limited course of Cytoxan that has to be given every day for a certain number of months to be effective. So I like Rituxan because then the onus is much less on the families to reliably give home medications for prolonged periods of time. We know it works, we know it's going in, and for many families who ask me, well, what would you do? I now recommend that Rituxan. Did you have a question, or? Oh yeah, I'm almost done. And then, so what happens if the steroid, if the patient doesn't respond to steroids? Then along the same lines, one of the questions is, did that child really get those 2 milligrams per kilogram every day? Usually after 4, 5, 6 weeks of that much steroids every day, you can tell the child should look somewhat Cushingoid, some children more than others. There is a, when in doubt, we sometimes use 6 Monday, Wednesday, Friday, or every other day or whatever, high-dose IV steroid infusions. There's some data about that being a good indicator or a good approach to force the question, is this child really steroid resistant, or is this child just acting like a steroid non-responder because he didn't or she wasn't getting their steroids reliably at home. And then the next steps in somebody who really failed steroids are, you consider starting calcineurin inhibition because there's a higher likelihood that this child will have FSGS, and calcineurin inhibition is worth a try in that condition. In parallel, you can work towards a kidney biopsy and adjust treatment based on the results. And then again, especially more recently, pursue genetic testing. Again, for steroid treatment guidelines out there that are generated by international consensus groups and things. And then more recently, there's a lot new knowledge about genetic testing. This is a review that recently came out in our main journal. It summarizes some of the situations where genetic testing should be especially considered in steroid-resistant nephrotic syndrome. And these are all the molecules, some of which I showed you earlier in my little glomerular filtration barrier pictures. These are all the molecules for which there are now known mutations that are associated with nephrotic syndrome that you can test for if you have access to genetic testing capabilities, which is, in theory, commercially available. It's, at least in the United States, still problematic to get it done because of insurance reasons. And one of the reasons why it's nice to have genetic testing is because you can rarely, but sometimes find a mutation like we were able to and recently publish in one of these molecules that you can actually treat. So coenzyme Q2 nephropathy can be treated just with coenzyme supplementation, and the nephrotic syndrome will go away. So you don't, if you find that mutation in a steroid-resistant nephrotic, you don't have to worry about calcineurin inhibitors. You don't have to worry about progression to chronic kidney disease. You just do coenzyme Q supplementation, and it works very well. And so from this review article, here are the key summary points about genetic testing. Mutations are now quite well known to be detectable in steroid-resistant nephrotic syndrome. They're helpful when in designing personalized treatment. Like I mentioned, you may be able to avoid aggressive immunosuppression, even more aggressive immunosuppression. You may also be able to prognosticate if you find a mutation that's really been associated with treatment-resistant progression to end-stage renal disease. It's nice to set that expectation with the family so you can plan for renal replacement therapy down the road, et cetera, et cetera. And it's, once again, pretty available in many regions of the world now, at least in theory. Yep. And that's why I'm saying shukran.